Imagine intentionally heating the most delicate, sensitive human tissue you can possibly think of to like 116 degrees Fahrenheit.
Right, which sounds completely insane.
Yeah, exactly. On paper, that sounds like a fast track to the burn unit. It sounds like, well, like sous vide cooking, not actual medicine.
It really does.
But in the, rapidly evolving world of modern gynecology, doing exactly that and without a single drop of anesthesia is actually the secret to waking up this dormant biological factory.
Which completely flips the traditional script on medical technology.
Mhm.
I mean, for decades, the default approach to fixing a physical problem in the body was this very binary point-and-shoot mentality.
Right, like see a problem, blast it.
Exactly. You find the flaw, you aim a laser at it, and you burn it away, or you cut it out. It's neat, it's linear, and it basically treats the human body like a simple machine.
But the human body is not simple, especially when we step into the world of the female pelvic floor and vaginal anatomy. That whole point-and-shoot laser mentality just totally falls apart here.
Oh, completely.
Because you can't just zap a complex organ that is simultaneously experiencing, multiple entirely different types of aging and structural breakdown.
Right, you're dealing with a highly dynamic environment.
Yeah.
The tissue at the very entrance of the vaginal canal is biologically entirely different from the tissue just a few centimeters deeper inside.
Which is wild to think about.
Yeah, so you can't treat them the same way. It requires a level of bespoke tailoring that traditional lasers just couldn't really offer.
And that brings us to the core of what we're doing today. Welcome to the deep dive. We have an incredibly revealing stack of sources in front of us, giving you a look behind the curtain of modern medical aesthetics.
Some really fascinating stuff in here.
Definitely. We are pulling from clinical trial data, medical clinic FAQs, the UK's NICE guidelines, and even the literal step-by-step manufacturer procedural protocols for temperature-controlled radiofrequency devices.
Yeah, these are the devices you might have heard of out there, with names like Thermiva, Forma V, or Morpheus 8V.
Right. And we're totally bypassing the glossy marketing brochures today. We're looking directly at the instruction manuals and the hard clinical data that doctors actually use to make decisions in the treatment room.
Because that's where the real story is.
Exactly. So our mission for you listening today is to extract the exact clinical mechanics of non-surgical vulvovaginal rejuvenation. And we're setting a highly specific real-world challenge for this deep dive.
A very tough challenge.
Yeah. How do clinicians actually customize these high-tech radiofrequency protocols for a patient who is suffering from both introital thinning, which is the structural breakdown of the tissue at the vaginal entrance, and severe deep canal dryness?
It's basically the ultimate clinical test for this technology. Because presenting with both of those symptoms simultaneously, well, it forces the clinician to constantly adapt their tools, their pressure, and their temperature to the immediate terrain of the body.
So we're giving you the clinical playbook. We're going to look at how doctors mix, match, and modulate energy to treat these complex overlapping symptoms without a single surgical incision. But before we get into the customization for those specific areas, we really need to understand what radiofrequency or RF energy is actually doing to human tissue on a cellular level.
Right.
Because the sources make it very clear this is not a laser.
Right. No. Traditional ablative lasers work by essentially burning microscopic holes into the surface of the tissue.
Like actually damaging the top layer.
Exactly. They cause deliberate, controlled damage on the very top layer to face the body to heal that damage. But temperature-controlled radiofrequency is fundamentally different because it's non-ablative.
Okay.
It leaves the surface completely intact. It uses an electrical current to push heat into the deeper connective tissue layers, the submucosa, safely bringing it up to a therapeutic range of like 40 to 45 degrees Celsius.
So the energy completely bypasses the surface mucosa.
It dives right underneath it. And when that deep connective tissue hits that sweet spot of 40 to 45 degrees, you get two distinct biological reactions. First, there's an immediate denaturation of the existing collagen fibers.
Denaturation meaning?
The heat physically alters the shape of the collagen, causing it to instantly contract and tighten.
I always picture this initial reaction like taking a stretched out, baggy wool sweater and tossing it into a hot water wash.
Yeah. Perfect analogy.
You pull it out and it has immediately shrunk back to its original tight shape. It's a pure physical reaction to the heat.
Exactly. But while that sweater shrinks today, that dermal stress is also acting as a biological alarm clock for tomorrow. That's the secondary long-term effect.
Okay, what happens tomorrow?
The heat activates dormant cells called fibroblasts, which triggers this massive months-long healing cascade. The body begins a process of building brand new neocollagenesis and brand new elastin fibers to reinforce the area.
So the hot water shrinks the sweater, but it also tricks the body into, I don't know, opening up a factory to knit brand new, highly elastic fibers from scratch.
That's exactly it.
And reading through the sources, relying on an electrical current instead of a laser beam, gives RF some massive practical advantages. Because it doesn't use light, the patient's skin type or natural pigmentation doesn't matter at all, right?
Not even a little bit. There is zero risk of causing discoloration or pigmentation damage.
Plus, radiofrequency energy naturally thrives in moist, hydrated environments.
Which obviously makes it the ideal modality for vaginal tissue.
Right. But I have to say, applying raw electrical heat to such an incredibly sensitive area sounds terrifying.
Oh, absolutely.
We're talking about delicate tissue. How does a clinician pump 116 degrees of heat into the body without causing third-degree burns?
So the secret is in the temperature-controlled aspect of the hardware. The modern wands the clinicians use, like the Thermiva probe, they have these built-in thermistors.
Okay.
These sensors are constantly reading the tissue's temperature and sending real-time feedback to the main computer multiple times every single second.
Wow, so it's super fast.
Incredibly fast. The machine then automatically modulates the power output, shifting seamlessly between, say, a 20-watt and a 50-watt capacity based entirely on the tissue's impedance.
Tissue impedance. So we were talking about how much physical resistance the tissue is giving to the electrical current at any given microsecond?
Yeah, the machine is constantly doing the math. If the tissue suddenly gets a fraction of a degree too hot, the computer instantly drops the power.
That's wild.
This real-time feedback loop removes the human error of overheating the tissue. And practically speaking, because the machine is constantly auto-regulating, the clinician doesn't need to use systemic anesthesia, local numbing shots, or even those messy surface cooling gels.
Which explains a detail in the clinic FAQs that I found so surprising. The sources consistently describe the actual patient experience as feeling like a painless hot stone massage.
Yeah, that's the most common comparison.
And there is zero downtime. A patient can literally get up from the treatment table and go right back to work or go to the gym.
Exactly. The technology manages the immediate risk of burns, which frees the clinician to focus entirely on the application and their physical technique.
Okay, so with that foundation laid, let's put this into practice and look at the first half of our specific clinical challenge.
Let's do it.
If we have a patient suffering from severe deep canal dryness, which is a very common, very debilitating part of genitourinary syndrome of menopause, or GSM, what does the clinician actually do? How do they tailor this hot stone massage for the deep internal tissue?
Well, the procedural guidelines provide a highly specific roadmap for this. The clinician takes the RF electrode. The Thermiva wand is described in the protocols as having this ergonomic S shape, and they insert it internally.
Okay.
They are instructed to insert the wand until they meet natural resistance at the cervix or the vaginal cuff if the patient has had a hysterectomy. From there, they back the wand out about 2 to 3 centimeters.
Just to give a buffer zone and protect the cervix from direct heat? Right.
Precisely. That establishes the maximum safe treatment distance. Once they have that positioning, the protocol parameters shift. For the deep internal tissue, the target temperature is pushed to the absolute high end of the therapeutic range, usually aiming for between 45 and 47 degrees Celsius.
Which is that 116 degrees Fahrenheit we mentioned earlier. A very intense, sustained heat.
Yeah, very intense. And the clinician maintains that exact heat by performing slow, continuous sweeps. They mentally divide the vaginal canal into distinct zones, the anterior wall, the posterior wall, and the lateral walls.
Okay, breaking it down into sections.
Right. And they move the wand continuously over these zones for about 12 to 20 minutes total. That breaks down to about 3 to 5 minutes of sustained targeted heat per zone.
I have to pause here because this brings up a massive contradiction that I think anyone listening would be wondering about.
What's that?
If a patient's primary debilitating problem is severe dryness, how does applying 116-degree heat to the inside of their body not just bake the tissue? I mean, doesn't applying intense heat dry things out even more? It intuitively feels like taking a completely dry, brittle kitchen sponge and throwing it into a hot oven.
It's a completely logical assumption, but it highlights a fundamental misunderstanding of how living biological tissue responds to stress compared to, an inanimate object like a sponge.
Okay, explain that.
The heat from the wand isn't sitting on the surface evaporating the remaining moisture. Because the RF energy bypasses the surface and heats the submucosa underneath, it is applying a controlled thermal stress to the cellular foundation.
Oh, I see. We aren't baking the surface. We are sounding an alarm in the basement.
That's a great way to put it. When the body detects that deep thermal stress, it initiates an aggressive rescue response. The heat stimulates the local release of neuropeptides and promotes a biological process called angiogenesis.
Angiogenesis, the body physically building brand new blood vessels from scratch.
Yes. It lays down completely new vascular plumbing. The body builds these new pathways to rush blood into the area to rescue the tissue it thinks is under attack from the heat.
Wow.
And it is this massive long-term increase in local blood circulation that ultimately restores the tissue's natural ability to produce its own moisture and lubrication.
That is fascinating.
The heat doesn't dry the tissue out. The heat demands a rush of blood, which subsequently rehydrates the tissue from the inside out.
That is just brilliant. It's essentially biohacking the body's own emergency response system to bring hydration back to a dormant area.
Exactly.
And it perfectly explains a specific detail in the clinical data. The sources note that while a patient might feel that immediate tightening effect on day one, our wool sweater shrinking the actual moisture improvement, the real relief from the dryness doesn't become notably different until about 2 weeks after the treatment.
Right, because building new blood vessels takes time. The body needs those weeks to physically construct the pathways and for the enhanced circulation to establish a new baseline of hydration.
Okay, so this is where the true customization comes in, though, because the deep canal is only half the battle for our hypothetical patient.
Right, the terrain is about to change.
Once the clinician finishes that 20-minute internal sweep, they slowly withdraw the probe to treat the introitus, the vaginal entrance, and the external labia. But the biological terrain here changes completely.
The contrast is drastic, yeah. The internal mucosa is designed for a specific function, but the external tissue of the vulva and the introitus is fundamentally different. It is much closer to the skin on your arm.
Okay.
It is thicker, it has a much denser blood supply, and it is packed with highly sensitive nerve endings compared to the deep internal canal.
So you cannot just drag the wand out and keep doing the same slow sweeps. The playbook has to change.
The clinical protocols dictate a distinct shift, yes. Externally, the temperature target usually broadens a bit, aiming anywhere between 42 and 47 degrees Celsius depending on patient tolerance.
Makes sense.
But because this skin-like tissue is structurally more resistant to the electrical energy, the clinician has to physically alter their technique. The manuals explicitly state they must apply firmer pressure to the electrode against the tissue to force the heat to penetrate and reach that target temperature.
So they're actively reading the tissue's physical response. The manual says they are watching for clinical endpoints. What does that actually look like to the doctor?
They are looking for visible erythema.
So a visible reddening of the skin, almost like a mild, immediate sunburn flush.
Exactly. That flush is the visual confirmation that the target temperature has penetrated deep enough in that specific zone of the labia or introitus.
It's remarkably similar to like a high-end skincare routine. You would never use the exact same intense chemical peel on the incredibly delicate, thin skin right under your eyes that you would use on the thicker, oilier skin of your forehead.
Right, you modulate the tool based on the terrain.
But what happens if this patient's introital thinning is severe? What if it's advanced structural atrophy that a standard, smooth RF wand just can't quite fix?
This brings up the limitations of standard bipolar radiofrequency. If a patient presents with advanced tissue thinning, profound laxity, and structural loss at the entrance, a gentle wand, like the Forma V or Thermiva, which relies entirely on pushing heat down from the surface, it might not be enough to trigger the necessary structural repair.
So it's a backup plan.
In those specific cases, the clinician will switch devices entirely. They move from a smooth wand to a fractional RF microneedling device, like the Morpheus 8V.
Microneedling combined with radio frequency, that sounds like a massive escalation in intensity.
Oh, it is. The mechanics are entirely different. The Morpheus 8V uses a matrix of tiny gold-plated needles to physically puncture the skin, penetrating up to 3 millimeters below the epithelium.
Ouch!
Yeah, instead of pushing heat down from the top, it delivers the RF energy directly into the deep structural layers through the tips of the needles. By combining the physical microtrauma of the needles with the deep thermal heat, it triggers a much more profound, aggressive structural remodeling of the collagen.
But by physically breaking the skin, you're crossing a line. It's more invasive now.
You definitely lose the painless hot stone massage aspect. Unlike the standard RF wands, which require zero downtime, The Morpheus 8V requires a strong topical anesthetic cream applied beforehand to manage the pain of the needles.
Right.
And patients are typically advised to avoid intercourse, submerged baths, or strenuous exercise for at least a few days to a week to prevent infection while those micropunctures heal.
Yet, looking at the clinic protocols in our sources, doctors will frequently combine these two very different modalities in a single visit for a patient dealing with our exact combination of symptoms.
That is the pinnacle of modern customized care. A clinician will use the gentle volumetric heat of the smooth bipolar wand for the internal sweeps, relying on angiogenesis to cure the deep canal dryness.
Okay.
And then during the very same session, they will wipe the wand down, apply numbing cream to the entrance, and switch to the fractional RF microneedling device to tackle the severe, advanced structural thinning of the introitus.
They are stacking the treatments to build a completely bespoke protocol. They're addressing the lack of blood flow internally and the lack of structural integrity externally.
Which illustrates perfectly why a one-size-fits-all approach to pelvic health always fails. The ability to stack these modalities, combining deep RF for moisture and microneedling RF for structural integrity, is what makes these modern clinical protocols capable of handling such complex presentations.
Listening to the mechanics of this customizable technology, the results sound little short of miraculous. If you are a patient whose quality of life has been derailed by severe pain, dryness, and thinning, it sounds like you should just skip the drugstore aisles and jump straight into a radiofrequency clinic.
It's very tempting.
Right.
No.
Why bother with anything else? But our stack of sources includes the UK's NICE guidelines. That's the National Institute for Health and Care Excellence. And they provide a very crucial, sobering reality check on exactly that impulse.
The NICE guidance is vital context here, especially when dealing with high-tech aesthetics. They explicitly state that energy-based devices, whether it's lasers or radiofrequency, should not be used as the first-line treatment for genitourinary syndrome of menopause, vaginal dryness, or tissue thinning.
If you're a patient in pain and you have the money and the clinical data shows this works, that guideline probably sounds incredibly frustrating. I mean, is this just bureaucratic caution, or is there a real medical danger in skipping straight to the high-tech biohacks?
No, it's not just bureaucracy. The guidelines are rooted entirely in patient safety and diagnostic clarity. NICE mandates a strict, stepwise approach to care.
Meaning you start small.
Right. A patient must start with foundational conservative treatments first. This means trying regular, non-hormonal vaginal moisturizers, like hyaluronic acid gels. It means finding suitable lubricants during intimacy. And if those over-the-counter options fail, the next step is typically low-dose, localized vaginal estrogen therapy.
The basic building blocks of pelvic health. But why is it actively harmful to just bypass the moisturizers and jump to the RF device if a patient wants faster, more permanent results?
Because if a doctor immediately throws a high-tech radiofrequency device at a complex pelvic problem without establishing a baseline of conservative care, it becomes scientifically and medically impossible to know what is actually causing the patient's symptoms.
Oh, I see.
You completely muddy the diagnostic waters.
You risk masking the root cause of the pain.
Exactly. Let's look at the red flags the sources highlight. Imagine a patient comes in with severe pain and a sensation of tearing or dryness. If you immediately use an RF wand, you might temporarily increase blood flow, but you might be completely missing a tethered perineal scar from a past childbirth that is actually causing the mechanical pain.
Right, the wand isn't going to fix a mechanical scar issue.
Exactly. Or you might be ignoring undiagnosed postmenopausal bleeding, which could be an early warning sign of a malignancy. You could be applying 116-degree heat over an active, undiagnosed bacterial infection. Or you could be entirely missing a severe pelvic organ prolapse.
Wow, okay. In all of those scenarios, a hidden scar, a silent infection, a structural prolapse radiofrequency is either going to be completely ineffective or outright contraindicated. You could easily make a hidden infection much worse by throwing heat and increased blood flow at it.
Precisely. Clinicians have an obligation to rule out those red flags first. Jumping straight to a shiny new device can mask underlying structural or biological issues that require a completely different medical intervention, like, corrective surgery, a course of antibiotics, or dedicated pelvic floor physical therapy.
But how does that strict caution reconcile with the clinical data we've been reading? We have studies in our sources like the landmark Millhiser study from 2010 showing an 87% improvement in tissue laxity and sexual function at 6 months. That is real data showing profound relief for patients.
The early data is incredibly promising, and those success rates are life-changing for the patients in those trials.
Yeah.
However, Authoritative bodies, like NICE, are looking at the entire landscape of medical evidence.
Right.
They remind us that while these smaller prospective studies show fantastic results, the industry still lacks large-scale, double-blind, placebo-controlled long-term studies. When a treatment is still relatively new to the broader medical field, governance demands that it be used responsibly as a secondary or tertiary step in a proven clinical pathway, not as a shiny first resort.
It's about respecting the process of diagnosis. You wouldn't demand a dentist perform a complex root canal before they ask if you've tried brushing your teeth and flossing.
That's a great comparison.
You build a foundation of basic care, and if that foundation genuinely isn't enough to resolve the symptoms, then you bring in the bespoke, temperature-controlled technology.
It protects the patient. It ensures that when a clinician finally does use the RF technology, they are using it on the exact right patient for the exact right reasons, with the highest possible probability of success.
That is a phenomenal reality check to ground all of this high-tech optimism.
Mhm.
So to quickly recap the journey we've taken you on today.
It's been quite a journey.
Yeah. We started by looking past the laser analogies to understand how radio frequency bypasses the surface to heat the deep submucosa, shrinking collagen like a hot sweater and waking up the body's long-term healing cascade. We saw how clinicians customize that for deep canal dryness, applying 45 to 47-degree heat to trigger angiogenesis, literally demanding the body build new blood vessels to rehydrate the tissue from the inside out. We watched them ship their technique at the entrance, applying firmer pressure and even swapping to microneedling devices to tackle severe structural thinning. And finally, we grounded all of that customizable power in the strict, stepwise medical guidelines that keep patients safe from misdiagnosis.
It really serves as a perfect example of how treating complex human biology requires nuanced, highly adaptable medicine. But, stepping back from the immediate clinical protocols, synthesizing all these sources leaves me with one final, deeply provocative thought about the nature of aging itself.
Oh, where does this lead us?
Well, for decades, the medical community has viewed the thinning and dryness of these pelvic tissues as a strictly hormonal failure. We've largely accepted it as an inevitable, irreversible consequence of losing estrogen as we get older, a one-way street of biological decline.
Right, that's the standard narrative.
But if applying localized physical thermal stress can trick this exact same tissue into spontaneously regenerating its own youthful collagen and building brand new vascular networks from scratch, well, it suggests a totally different paradigm. It suggests that our bodies actually retain the latent capacity for youthfulness far, far longer than we ever believed.
The architectural blueprint for healthy tissue isn't gone. The construction crew just went to sleep. It just needs a different kind of signal, a thermal alarm clock, to start building again.
It really begs the question. As this energy-based technology continues to evolve, are we on the verge of treating biological aging not just by perpetually replacing lost chemicals and hormones, but by using targeted physical biohacks to simply demand the body wake back up and do the work itself?
That is an incredible thought to leave on, the idea that we might be moving from simply managing our decline to actively commanding our own regeneration. It definitely changes how you view getting older and what our bodies are actually capable of.
It really does.
Thank you for joining us on this deep dive. We hope it gave you a totally new perspective on the invisible, bespoke tailoring happening in clinics today and the science of how your body heals. Keep digging, keep questioning the science behind your health, and remember, your body isn't just a target waiting to be zapped. It's an incredibly complex instrument, and sometimes it just needs the right kind of thermal tuning. Catch you next time.